Welcome to Dead Giveaway. I'm Billy.
And I'm Carly.
This is a two-part podcast. In episode 1, I will tell a true story, but change the names and locations to try and see if my true crime-obsessed wife can discover the truth.
In part 2, Billy reveals the answers, and we will discuss the details of the case. Will I get it wrong, or will it be a dead giveaway?
Hello and welcome back, everybody.
Hello.
How are you?
Are you asking me? I'm good.
Yeah.
Okay.
We have no idea how they're going to be.
They're great. Everybody's having a fantastic day.
Fan-freaking-tastic.
Yes. And if you're not, stop it. Have a good day.
You've been told you're having a good day.
You are having a good day.
You're having a good day now. Yeah. Oh, man. Sorry for sniffling. We had the world's hottest seafood, I don't even know, like slaw soup.
It was so good. But yes,
so
my
good.
nose has not stopped running for the last 30 minutes.
My bottom lip is numb. Like,
But you can't stop. You couldn't stop eating it. It was so good.
yeah, I know. I'm a glutton for punishment.
No, I mean, in
apparently.
general, like I ate 2 bowls.
No, it was delicious.
Yeah.
Like, oh, man.
Billy can cook. That's all I'm going to say.
Well, I don't know how to season, though. That was, oof.
Well, I
God.
made the seasoning. You just put too much of it in there.
I did, but it's so good, too.
I should have told you that that seasoning mix had 3 whole tablespoons of cayenne pepper.
Right, I mistook it for like more chili powder.
No,
than
it was cayenne.
Yeah, believe me, I'm feeling it now.
Use sparing. I'm going to write use sparingly on the top of that container.
I'm gonna need somebody with a menthol cigarette to just help
Just blow some
blow on an
cooling
orifice
over
at
there.
some point.
Gross. Oh my God. They did not need to hear that on a Monday morning.
I'm willing to pay. That's all I'm saying. Anyways, hello everybody. We are glad you're here.
I mean,
And
you're
if
probably not.
still listening, and you have menthols. Let me know.
Oh my God.
Oh God! All right, we're gonna get into this. Oh my! Oh gosh! If I can, if I can pull myself together here.
Yeah,
I'm about to slip into a food coma.
I know.
Ooh, well, happy Monday, everybody! Thanks for tuning in, and yeah, we're just gonna jump right into it here.
All right, let's do it.
In the mid-'90s, the Neuro-ICU at Chicago Lakeside Memorial operated under conditions that, by modern standards, would be considered loosely controlled. Yeah, I know. Same. I'm fighting it back. I'm like, ugh. Man, sorry, everybody. Patient records were maintained on paper. Medication delivery relied on manual IV systems, and staffing shortages, especially overnights, meant hospitals regularly depended on contract nurses to fill gaps in coverage.
Uh-oh.
On the morning of July 12th, 1995, a code blue was called in room 812. The patient, David Miller, was a 62-year-old recovering from a stroke that had initially been classified as survivable. According to his chart, his condition had stabilized over the previous 24 hours, and he had been scheduled for step-down monitoring later that day. When the response team arrived, Miller was unresponsive. The attending physician, Dr. Leah Marino, led the resuscitation effort. It lasted approximately 20 minutes. And at 5:03 a.m., Miller was pronounced dead.
Uh-oh. Looks like we have an angel of mercy situation.
Maybe so. The preliminary cause of death... What was that? Sorry, my lip is numb. Sally is sold. All right, here we go. God. Whew. Oh, man. No, that shrimp was spicy. Like that was, yeah. Okay. The preliminary cause of death was listed as cardiac arrest. At the time, the death did not trigger any formal review. Cardiac complications are a known risk in post-stroke patients, and overnight deterioration is not uncommon in intensive care settings. There was no immediate signs of error, no conflicting notes, and no indication that anything outside expected medical risk had occurred. What would later matter was not the death itself, but where it fell in a sequence of similar cases that had not yet been connected.
Okay.
The first indication that something was off came through a routine quality assurance audit, not a criminal investigation. A staff nurse named Sarah was assigned to review mortality data for the unit. In the 90s, that process required physically retrieving records, death certificates, physician orders, nursing notes, etc., and cross-referencing them manually.
Yeah, that takes a lot of effort.
Over a 4-month period, Sarah identified a measurable increase in mortality within the Neuro-ICU, approximately 15% above baseline.
That's a lot.
That increase alone was not necessarily significant. Variations in patient populations, seasonal illness trends, and random fluctuation could all account for changes of that magnitude. What stood out was not the number of deaths, but their timing. Every one of the unexplained cases occurred during the overnight shift, specifically between 2 a.m. and 4 a.m.
Oh.
In each case, the patient had shown signs of stabilization or improvement during the day, followed by a sudden decline overnight that could not be clearly attributed to a single event.
So who's working the third shift or fourth shift? What is it?
I don't know. Overnight.
Yeah.
I just know it as the overnight. From a clinical perspective, there were plausible explanations. Overnight staffing levels were extremely low. Monitoring intervals were longer. Physicians were not always immediately available. And patients in critical care often deteriorated unpredictably.
Yeah.
So those changes can occur without warning, right?
Sure.
But when Sarah began comparing staffing assignments to the timeline of those events, a very obvious pattern emerged. 2 names appeared consistently across the same nights. Ethan Cole, a contract nurse assigned to the overnight shift, and Dr. Leah Marino, the attending neurologist responsible for these patients. At that stage, the pattern suggested correlation, not causation. It raised a question, but it did not provide an answer.
Yeah.
So the initial focus of concern leaned toward Dr. Marino. Within the hospital, she was regarded as highly competent but difficult to work with. Her approach to treatment was aggressive, particularly in cases involving sedation and neurological management.
I have a question. You said there were other deaths. Do you have a number?
Not yet.
Okay.
No, I mean, it's
there were just other
pretty
deaths that they were looking
consistently
into during the same
Yes.
time. Okay.
During the mid-90s, there was no universally accepted standard for sedation thresholds in critical care, especially for patients nearing end of life. Physicians were expected to balance pain management with the risk of respiratory suppression, often relying on individual judgment.
Yeah. Just kind of play it by ear and see what works.
So Marino consistently operated at the upper range of those thresholds. Sarah identified multiple cases in which Marino had ordered combinations of high-potency sedatives, fentanyl, Valium, and midazolam, administered within overlapping timeframes. While each individual order could be justified, the cumulative effect of those medications increased the risk of respiratory depression, particularly in patients already compromised by neurological injury.
Oh.
Internal nursing notes reflected concern about these practices. There were not formal complaints, but they were consistently brought up. Several entries described discomfort with the dosing strategies being used, noting that patients often transitioned rapidly from stable to unresponsive following medication adjustments.
Oh. So is it, okay. I wonder if it's miscalculation or if it's intentional or, you know.
We'll find out.
Okay.
On the night David Miller died, the chart showed that Marino had increased his sedation dosage at approximately 1:30 a.m. From a clinical standpoint, that decision could explain the outcome. Over-sedation leading to respiratory failure was a known risk, and in a patient with recent neurological trauma, even a marginal increase could trigger a fatal event. If the cause of death was medication-related, the responsibility would logically rest with the physician who ordered it.
Right.
And at that point in the review, that explanation was sufficient. It aligned with known risks, it fit the timeline, and it did not require additional assumptions. However, it left one critical variable unaccounted for. The chart documented what had been ordered. It did not document precisely how those orders were executed at the bedside.
In other words, it may not have been that doctor who gave the medication. It could have been somebody else, and that
So the mistake
person could have,
could have been on the person
Right.
who administered, right?
Which generally it's not the doctor who's the one doing the work. It's one of the nurses.
But this doctor has shown very hands-on. She's had a lot of complaints about being aggressive. So
they just don't have a way of proving on paper that that's what happened.
Exactly.
Okay.
As the audit continued, attention shifted the gap between physician orders and patient outcomes. That gap was controlled by the nursing staff. Ethan Cole was, again, a contract nurse assigned to the overnight shift. In the 90s, contract nurses frequently moved between hospitals, often working short-term assignments with limited oversight, beyond basic credential verification.
Yeah.
Their employment histories were distributed across multiple institutions, and comprehensive background tracking was not standardized. When Sarah reviewed Ethan's employment record, she found that he had worked in several major cities, including Atlanta, New Orleans, New York, a lot of big cities.
It kind of makes you wonder why he's jumping around.
Well, contract nursing, the
That's
week kind
true.
of goes
I
where
mean,
he's
and
needed.
people in the medical profession often do that just to find where they're best suited. And,
Exactly.
Yeah.
And as a contract nurse in the 90s, he was traveling all over. And
Yeah.
that was pretty common.
Just what he did.
So performance evaluations from those assignments described him as reliable, adaptable, and effective with high-risk patients. However, there were also some inconsistencies. Several assignments ended without clear documentation or completion, followed by immediate relocation to another facility. So
Like he would end his contract before he was supposed to and just go somewhere else.
Yeah, or be in breach of.
Yeah.
So in one instance, a hospital in Atlanta had experienced a cluster of ICU deaths over a short period.
Uh-oh.
The official explanation cited environmental factors, and the case was resolved through a civil settlement.
But also suspicious.
Yes, that's the whole point.
I know.
Yeah, exactly. So Ethan Cole had been assigned to those patients during that time. Individually, these details did not establish wrongdoing. They were circumstantial and could be explained by unrelated factors, right? But this does introduce a second possibility. If Dr. Marino's treatment plans created conditions in which patients were vulnerable to decline, a nurse with access to those medications could alter outcomes at the point of administration without leaving a clear record.
Yeah, easy to manipulate the situation, kind of, take it into your own hands, and you're following doctor's orders, but you're also kind of...
Exactly.
Yeah.
Just a hair over and can put them past the tipping point, right? So at that stage, the investigation no longer centered on a single suspect.
Okay.
It focused on 2 points in the same system. One where decisions were made and one where those decisions were carried out, right?
Yeah.
So you got doctor and you got nurse.
Yeah. So who's the one who's making either a mistake or doing it on purpose?
The first concrete irregularity emerged from the hospital's narcotics logbook. At that time, controlled substances were tracked manually. Each administered dose had to be recorded, and any unused portion required documentation as waste, witnessed and signed by a second nurse. Sarah reviewed all entries associated with Ethan Cole. The records appeared consistent at first, but the dosages were documented, waste was logged, and signatures were present where required. However, when she cross-referenced the witness signatures with staffing records, a discrepancy became apparent.
Oh.
Multiple waste entries were co-signed by the same nurse, Nurse Miller. According to scheduling records, Nurse Miller had been on medical leave for part of the period during which those entries were recorded.
Oh,
this
that's
created
not good.
2 possibilities. Either the staffing records were inaccurate or the signatures were not legitimate.
Yeah.
So if the signatures were not legitimate, the waste itself could not be verified. And if the waste could not be verified,
It could have been pocketing it.
the disposition of the medication remained unknown.
Yeah.
At that point, the investigation expanded beyond clinical judgment, and it introduced the possibility of
Right.
some nefarious deeds going on.
Yeah. Dirty deeds. Done dirt cheap.
Yep. So the case shifted further with the identification of a surviving patient. Leo Vance had been admitted following a stroke and experienced an overnight event consistent with the pattern observed in previous cases.
But he didn't die.
Unlike other patients, Vance survived.
Oh.
The survival was not due to intervention timing, but to a disruption in monitoring systems. A localized equipment failure prompted earlier than usual attention from staff, and interrupting the sequence that had been observed in other cases. So just by happenstance, because this was faulty, for real, divine intervention.
Yeah.
So without a complete monitoring record, the event relied on witness accounts. So Vance's wife was present in the room at the time of this account. She reported seeing a clinician at her husband's bedside during the episode, speaking to him in a low, controlled tone. And when asked to identify whether the individual was a nurse or a physician, she could not provide a definitive answer.
Oh. Male or female?
The lighting conditions were poor and the situation was chaotic. She's very old and her eyesight
middle of the night,
was not
she's tired.
good. Yep.
Yeah.
So Vance himself later provided a written statement. He recalled being told that it was time to rest and described the sensation of an injection immediately prior to his physical distress.
Oh.
However, he was unable to identify who administered the injection. So his testimony did not resolve the question. It just only reinforces that
something's happening, but they can't figure out who's doing it.
So by August 1995, the situation at Chicago Lakeside Memorial had moved beyond routine internal review. The hospital's administration made the decision to involve law enforcement at this time, but the case was not presented as a confirmed criminal investigation. Mm-hmm. At that point, there was no definitive evidence that a crime had actually occurred.
So they're just bringing them in to help determine if it's a crime.
Right. Okay. Or if it's just severe oversight and... Right. Lack of, just making...
Understaffing and not being able to take care of people.
Exactly. Yeah. So what existed instead of this was a very clear pattern, right? Either somebody is consistently making the same mistakes or they're doing it intentionally. And so you have a series of patient deaths occurring under similar conditions within a consistent time frame and involving the same small group of staff. Alongside that pattern were a set of irregularities that individually could be explained. However,
it's just kind of like in anything with police work. Like after you get through so many coincidences, it can't be coincidental.
Right.
There's just no way.
Medication orders that pushed upper dosing limits, but remained with a defensible range were often used.
Sure, but you've got people who are already having
all these issues,
stroke, cardiac issues, like they're going to be more susceptible to that.
And so the police are looking at where these are coming from, right? And so there's, again, a direct correlation between the writer and the administrator, right?
Yeah.
So narcotics logs that showed inconsistencies again, but not enough to conclusively prove diversion, right?
Yeah.
And so you've got to go back and look.
A lot of, in the 90s, it's a lot of...
And this is all manual, right? It's not necessarily
door knocking.
Let's check it up on the computer. Right?
They're going to have to actually go talk to people and hunt people down and all
So
that.
witness accounts also described unusual behavior, but stopped short of identifying a specific individual. Investigators approached the case with that limitation in mind. In a medical setting, outcomes that appear suspicious can often be explained by clinical judgment, patient condition, or system failure. Moving too quickly toward a conclusion risked misidentifying normal but aggressive treatment as intentional harm.
Yeah.
At the same time, delaying action risked allowing a potential pattern to continue. So the decision was conclusively made to just observe.
Keep a closer watch on what's happening because they don't know for sure if anything's happening.
Right.
Okay.
So Ethan Cole was nearing the end of his contract at Lakeside Memorial.
Oh, time for him to split.
He was scheduled to complete several more overnight shifts before transferring to another hospital. Dr. Leah Marino remained on rotation as the attending neurologist for the unit, continuing to write orders and oversee patient care.
Okay.
Hospital administration implemented additional oversight measures without formally notifying staff of the investigation. So they're just kind of doing this on the down low.
So yeah, it's kind of like not undercover, but
kind of, a little bit, yeah. So medication access logs were monitored extremely closely during this time.
Yeah.
Charting was reviewed in real time rather than retrospectively.
Good. Hope somebody's following around. Somebody's quietly following both Dr. Moreno and Ethan.
Supervisory staff increased their presence in the unit during overnight hours,
Good.
particularly during the 2 to 4 a.m. window that had been identified in the audit.
Good.
During this period, the pattern did not disappear. However, it also did not clarify.
So it kept happening, but nobody ever saw anything that would...
There were cases in which Dr. Marino's patients experienced rapid overnight decline when Ethan was not assigned to their care.
Oh.
In those instances, the same factors were present: high-potency sedation orders, neurological vulnerability, and sudden deterioration. Those cases supported the theory that the issue could originate at the level of the physician decision-making.
Yeah,
that's
if he's not there.
A tongue twister. Physician decision-making. At the same time, there were shifts in which Ethan was present, had access to medications, and no adverse events occurred.
Okay.
Those cases complicated the assumption that his presence alone explained the pattern.
Right. So now they're leaning more towards the doctor.
And from an investigative standpoint, the data remained inconclusive. Each theory, physician-driven, nurse-driven, or system-related, continued to fit the available evidence. The final shift of Ethan's assignment was handled a little bit differently. In the early morning hours, Sarah entered one of the patient rooms as part of the increased oversight protocol. The patient had been stable during the previous shift with no documented indication of imminent decline. Inside the room, Ethan was at his bedside and was holding a syringe.
Oh.
That observation by itself does not indicate wrongdoing. Administering medication was a routine responsibility that he was often doing. The patient's chart included active orders that could require intervention at that time, including conditional sedation adjustments written by Dr. Moreno.
Okay. So still...
Right. What was unclear in that moment to Sarah was the context in which Ethan was there with the syringe.
Right.
The medication had not yet been logged in the chart. There was no immediate entry indicating what was being administered or under which specific condition the order had been triggered. At that time, Dr. Moreno had written orders that allowed for discretionary dosing based on patient response.
Oh, so that means it's up to whoever's doing the care, in other words, the nurse, to determine whether they need it or not.
Right. Okay. And those orders did not always require prior authorization, and they were often carried out at the nurse's judgment. So from an investigative perspective, that created a ungodly amount of ambiguity.
Yeah.
So Ethan could have been administering a medication exactly as ordered. He could have been adjusting a dosage within the bounds of physician discretion, or he could have been acting outside of those parameters.
Right.
There was no immediate way to determine which.
Yeah.
Ethan did not attempt to conceal what he was doing, though, and he did not stop when Sarah came in. He acknowledged her presence and continued with his task as he would routinely. His behavior was fine. He didn't act out of the norm. This was routine work for Ethan.
Yeah, so you would think that he was doing what he was supposed to be doing, or what he was told to do.
The patient did not show signs of acute distress at that moment either. There was no active emergency, and no code blue had been called after the medication had been administered. So what we have is a snapshot of a nurse, a patient, and a medication being administered during a time frame that had already been that has been identified as significant, right? This is the window that these things typically happen in. So for investigators, the moment did not resolve the case one iota, and it also didn't give them any answers.
It raises more suspicion, but doesn't give you any. Yeah,
it reinforces the problem.
Right. Exactly.
And so
obviously something's happening, but we still can't tell what.
Exactly. So every element of the situation could be interpreted in more than one way.
Yeah.
And if the issue originated with physician orders, then the nurse's actions were consistent with standard care. If the issue originated at the bedside, then the orders themselves provided sufficient cover.
Right.
If the issue was systematic, then both individuals were operating within a structure that allowed for undetected error.
Right. Yeah.
So we have a pattern that's established, irregularities that are documented, potential explanations that are understood by everybody. And again, what remained unclear was where control actually existed. And without that, there was no definitive way to determine who was responsible for these deaths.
That's crazy.
Yep.
So there's nothing, then there's nothing they can do. You just have to keep
closely
watching and seeing until somebody dies again, basically. That's awful.
And especially when you think, oh, we caught him red-handed with the syringe, but he doesn't react.
Right. He doesn't react. He acts normal. He continues to do it. It's in the chart. Yep. And like you said, it was so like, okay, yeah, you could do this if they need it. It's up to you. You decide, like, you know?
Exactly.
Wow.
So
it's up to me then, huh?
Yep.
Man.
So do you think that it's Ethan or the doctor? Do you think that it's circumstantial, just in the wrong place at the wrong time?
Probably Sarah.
You think it's Sarah?
No, I'm kidding. Yeah, she's investigating it. She's just trying to blame it on everybody else.
Right.
I'm going to go with Ethan.
Okay.
I know of several Angel of Death or Angel of Mercy. What do you call it?
I'm not sure.
One or the other.
One of those two.
One of type of cases. So it's usually a nurse. I have heard a few doctors, but it's usually a nurse. So I'm going to go with Ethan.
All right. So that's your guess. We're locking it down.
All right.
She's guessing Ethan, folks.
Yes.
Whew. So this was a lot of windage on this one.
Windage?
Yeah, a lot of air. Yeah, but
all right.
Yeah. So if you guys enjoy the show, please drop us a review, and especially tune in to part 2 this coming week
on Thursday. Yeah.
Yes.
Oh, also, Billy's new song dropped on Friday.
Oh yeah.
So if you have Spotify, Apple Music, wherever you listen to music, go.
I'll see you
give
in
it
my
a listen.
dreams tonight.
Yeah,
it's the title. Yeah.
Really good song, written by his granddad years and years and years ago, and then Billy re-recorded it in his own style. So it's a really good song. Y'all should check it out.
I would appreciate it, you guys listening, sharing all of that fun stuff,
and then tell everybody you know, every single one, to listen to it as well. All of them.
If you want to listen to it, I will put the link down in the show notes if you guys are curious. Our socials are going to be down there as well, as well as our Patreon. I am so tongue-tied today. My tongue is still numb.
I'm telling you.
I'm like, oh my God. It was so spicy. I looked like I was wearing lipstick. That's how red my lips were.
Mexican food to shame.
Oh my gosh.
It was hot.
It was insane, y'all. Like, it was crazy. Anyways, we're going to stop and let you get on with your day.
We won't talk about our food anymore.
If you guys want to ask us any questions, have any suggestions, deadgiveawaypodcast@gmail.com. And you guys are great.
Yeah, we'll see you in a few days.
See you later. Bye.
Bye.